Hello and welcome to MK's Medical Review series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at medical topics in depth. Today we're going to be looking at intestinal obstruction. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. Grab your piece of paper, grab your pen, and let's go. So today we're going to be looking at intestinal obstruction. So this is pretty much a restriction to the normal passage of intestinal contents. Remember, whenever you eat, the food is going into your mouth. You're going to chew it up, break and roll it up into a bolus. This bolus is going to be swallowed through the process of swallowing or deglutition. It's going to pass through the esophagus, eventually reach the stomach. From the stomach, it's going to be digested, or rather digestion is going to start, pretty much the digestion of proteins, then eventually passed on to the small intestines, which are divided into three parts: the duodenum, which is the first part, the jejunum, which is the second part, and the ileum, which is the third part. Then from the ileum, you get into the ascending colon. You then move to the transverse colon, the descending colon, the sigmoid colon, the rectum, and eventually the anus, where this food is going to be passed out. So if there's any restriction to this normal passage of intestinal contents, you refer to that as intestinal obstruction. So the obstruction is pretty much in the intestines. Now, obstructions may either be complete, meaning that there's a total blockage of the lumen, or they may be incomplete, meaning that there's a partial blockage, meaning a few of the contents can leak through, air can leak through, and sometimes even some small amounts of bowel contents or bowel movements could be made. So when you think of intestinal obstruction, you can divide it pretty much into two main groups. There's what is known as adynamic intestinal obstruction or paralytic. This is where there is no physical obstruction that is present. Or it can be dynamic or mechanical, where there is an actual physical obstruction that is present. But what you really need to note is that the two most common causes of intestinal obstruction are adhesions, most commonly due to previous surgeries, and hernias. So how do we classify intestinal obstruction? It may be classified etiologically. You can classify it according to the speed of the onset. You can classify it according to the site of obstruction. You can classify it according to the nature of obstruction, or you can classify it whether it's congenital versus acquired, where someone is born with it or someone gets it along the way. So etiologically, they can be divided into dynamic or mechanical causes. This is where there's an actual physical obstruction. We shall see later on, as we look at the dynamic causes, that they can be further divided into causes that are causing obstruction within the lumen. You refer to those as intraluminal. Causes that are affecting the wall of the lumen, you refer to that as intramural. And causes that are outside the wall, you refer to those as extramural. Then adynamic is pretty much physiological obstruction. It can be a problem with the contractility of the gut, such that it fails to push the food forward or propel the food forward, or maybe the gut itself may be paralyzed, for example, in paralytic ileus. Then, according to the speed of onset, intestinal obstruction can be classified as acute, chronic, as well as acute on chronic. So acute is much more common in the small bowel, and it's going to be having a rapid onset, and they're going to be very severe symptoms. Chronic is usually insidious. It will have a gradual and subtle presentation over weeks, and it's much more common with carcinomas of the large bowel. And then acute and chronic is also common in the large bowel, where a chronic obstruction suddenly becomes complete. Then, according to the site of obstruction, you may classify it as a high obstruction or small bowel obstruction versus large bowel obstruction. Then, and according to the nature, this is just simply looking at whether the blood supply to that segment of the gut has been compromised or it hasn't. If the blood supply is not compromised, you refer to that as a simple obstruction. If the blood supply has been cut off to that segment of the bowel, you refer to that as strangulation. This could happen with hernias, which we refer to as strangulated hernias. It could happen with volvulus. It could happen with intussusception. So volvulus is just simply the gut twisting on itself, and then intussusception is simply the gut telescoping into itself. So one part of the gut enters into another part of the gut. Then, of course, it could be also due to adhesion bands. And often, if the blood supply is not restored as soon as possible, then the bowel may actually begin to die by necrosis, and eventually it may perforate. Then there are other causes that may be congenital, meaning that a child is born with them, or acquired, meaning that someone gets them along the way. I shall give you a few of these causes later on. So etiologically, like I already told you, dynamic causes are due to mechanical obstruction. So peristalsis is going to be against a mechanical obstruction. And it may either be acute or it may be chronic. Now, these dynamic causes or these mechanical causes can be further classified as intraluminal, meaning within the lumen, intramural, meaning within the wall, and extramural, meaning outside the wall. So causes that can lead to intestinal obstruction within the lumen, you could think of fecal impaction. Like, for example, if you have fecal matter that has remained in the gut for a very long time, like, for example, in people with a poor bowel habits, the water from this gut can be, or the water from these contents of the intestines can be absorbed such that now the fecal matter becomes very hard and it becomes impacted on each other and it fails to move. So that can lead to intestinal obstruction. You could sometimes have some foreign bodies. You have children that swallow objects, even adults to some extent. That would be very weird though. You have some adults that can swallow some foreign bodies. You can have a food bolus that can actually be there. Sometimes you may have parasites that may completely block the lumen. You may have tumors that are growing into the lumen, especially the pedunculated tumors. They could be polyps as well. You could also have bezoars. So bezoars is just simply this bolus of indigestible material. For example, it could be hair bezoars, and they can also block the lumen. You could also have what is known as gallstone ileus. So in gallstone ileus, that's where you have this very, very large gallstone that is in a chronically inflamed gallbladder. So this chronically inflamed gallbladder adheres to the wall of the duodenum. So what is going to be happening is that slowly but surely the walls of the gallbladder and the walls of the duodenum are going to erode into each other, such that you make this abnormal connection between the gallbladder and the duodenum, such that that very large stone that is causing pressure necrosis on these two organs can erode into the wall of the gallbladder, erode into the wall of the duodenum, and the stone will then get impacted down in the small intestines when it enters into the duodenum and it's moved along the small intestines, causing obstruction. This is very, very common in the small terminal ileum. Then intramural causes, meaning that the problem is within the walls. You could have things like strictures, which are often due to tuberculosis. You could also have tumors, carcinomas, and lymphomas are notorious for doing this. Sometimes you could have some congenital atresias, and atresia is just simply failure of development of a normal tube or an opening of a tube. So a child can have duodenal atresia where the rest of the duodenum and the rest of the small intestines fail to develop. Of course, if this isn't corrected as soon as possible, it may become incompatible with life. Sometimes you can have diverticulitis, which is just simply inflammation of the diverticula, which are outpouchings from the gut. You may also have inflammatory disease such as Crohn's disease, where you form these ulcers or ulcerations in the walls of the gut, and these can form strictures that can eventually block the passage of intestinal contents. Sometimes it could be extramural, meaning that the causes are outside the wall. So you could have some bands and adhesions, which are by far the most common causes of intestinal obstruction. You could have hernias, which are the second most common causes. You could have volvulus, where the gut twists on itself. You could have intussusception, where the gut telescopes into itself. This is much more common in children. You could also have compression by tumors, like, for example, nodal tumor deposits. You may also have adynamic, where peristalsis is pretty much absent, like, for example, in paralytic ileus, or it may present as a non-propulsive form, like, for example, in mesenteric vascular occlusion or pseudo-obstruction. Now, when you talk about congenital causes, this means that someone is born with this. You could have anorectal malformations, like, for example, if someone doesn't have an anus, they won't be able to pass meconium, which is the first quote-unquote stool that a child passes. Then you may have volvulus neonatorum, where the gut of the neonate twists on itself. You may have meconium ileus, where the meconium is thick and it actually plugs the GIT. You may have Hirschsprung's disease, which I already discussed in the prior video, where you have failure of migration of the myenteric as well as the submucosal plexi, and you lack ganglion that are going to be innervating the distal segment of the bowel. So it means that there won't be any peristalsis in the distal segment of the bowel. Then you may have malrotation, you may have bands and adhesions, you may have intestinal or even duodenal atresias. Acquired causes include hernias, which are the second most common cause, postoperative, which are often due to adhesions. Intussusception, which is telescoping of the bowel. You could have roundworms that could clog up the lumen, gallstones, which could enter, especially the very large gallstones, which we referred to earlier on as gallstone ileus. You may have TB and even malignancies. So we shall begin and talk about dynamic intestinal obstructions, because those are the ones that are very, very common. So remember that here you're going to be having a mechanical blockage to the normal propulsion and passage of intestinal contents. So remember that this can be acute or chronic, or it can be acute on chronic. So the causes can be classified as luminal, meaning they are within the lumen. You refer to it as intraluminal, like I already mentioned in the prior slide. You could also have intramural, meaning that they are within the walls, or it could be extramural. So I want you to engrave this on your mind, that whenever you're having lists of causes, whenever you're having lists of clinical features, find a way to classify them. That makes learning medicine very, very easy. And remember that adhesions are by far very common in the small bowel obstruction than they are in large bowel obstruction. So they're going to be accounting for 80% of intestinal obstruction that is going to be occurring in small bowel. And about 20% of this intestinal obstruction is going to be happening in the colon. And out of that 20%, 70% is often due to malignancy, while 30% is due to volvulus, is due to diverticulitis, is due to some inflammatory causes such as tuberculosis. And the mortality of bowel, if there is no strangulation and the blood supply is intact, is about 3%. But if the blood supply is affected in a strangulation, then it goes up to 30%. And of course, recurrent obstructions are very common in adhesions, which we do sometimes manage conservatively, but we shall come to management later on in this video. So the different causes of intestinal obstruction ranked according to percentages. As we can see here, adhesions are by far the most common causes, about 40%. You have carcinomas here, 15%, obstructed hernias here, 12%, inflammatory conditions, 15%, fecal impaction, 8%, pseudo obstructions, 5%, and then other causes, 5%. So now let's focus on the pathogenesis and the pathology that's going to be the intestinal obstruction, because this is very important. It will help you understand why we do certain things in management. It will help you understand why a patient is going to be presenting in this way. Even some clinical features that you're going to be seeing on the patient, if you understand the pathogenesis and the pathology, it'll be very easy for you to remember the clinical features. So we shall divide the gut into 3 parts. You have the part before the obstruction, so that's the part that is proximal to the bowel obstruction, which is this part here. Then you have the part that's at the site of obstruction, which is this part here, which is shaded in red. And of course, you have the part that is distal, that's after the obstruction. So the food is supposed to be going in, or the bowel contents are supposed to be moving in this direction, okay? So from part A, so we shall label proximal dilated bowel here as part A, the obstructed bowel as part B, and of course the distal segment here will be part C. So we shall discuss each of those and see what happens at each of the stages. That's how you're going to have a very good understanding of what is happening in intestinal obstruction. So we'll begin with the proximal bowel. So remember that you now have this obstruction. Suppose, let me give you an analogy that will help you understand. Suppose you are traveling with a group of people, and these people find that you have an obstruction on the road. There's a log that's on the road there. And you really need to leave, and you really need to go past this because you really need to get to your destination. So what's the right thing to do? Get off the car, push the log out of the road. Isn't that so? It is. So you start pushing that log out of the road, and you'll reach a point where if this log isn't moving, what are you going to do? You keep pushing. So you'll keep pushing that log in an attempt to move it out of the road so that you can go on with your journey. You won't turn back because you're already too far gone. But you reach a point where you push, and this log isn't moving, and you eventually get tired. So when you eventually get tired, you give up. Okay, and sometimes you may even decide to go back and use another route. So I want you to keep this analogy in your mind. So when you have an intestinal obstruction, there's going to be increased peristalsis. So there's going to be hyperactivity of the bowel before the obstruction. So this peristalsis can actually even become vigorous. This is because it's attempting to overcome this obstruction. So now these vigorous peristaltic contractions are happening in clusters, and they are the ones that are going to be responsible for this severe colicky abdominal pain that's going to be associated with intestinal obstruction. So it means one of the clinical features that we're going to be seeing in intestinal obstruction is severe colicky abdominal pain. Then if this obstruction is of course not relieved or it's not released, then the peristalsis is going to stop. It's going to cease, and eventually that segment of the gut is going to become flaccid. So there's going to be some flaccid paralysis, and there's also going to be dilatation of the bowel. So it means that if the other cars that are also coming behind you, they'll stop there and they'll all begin to accumulate there. So keep that analogy in mind. So remember that in the gut you have fluids that are being produced. Saliva is about 1,000 mils per day. The stomach produces about 2,000 mils per day. The pancreas is going to be producing about 1,500 mils per day. The bile is going to be about 1,000 mils per day. The intestines themselves secrete about 3,000 mils per day. And where are these things accumulating? They're accumulating prior to the obstruction. So you have 1,000 from saliva, plus 2,000 from the stomach, that's already makes 3,000, plus 1,500, that's going to be making 4,500, plus 1,000 from bowel, that's going to be making 5,500, plus 3,000, that's going to be about 8,500. So you have about 8,500 mils or 8.5 liters proximal to that in a day, proximal to the obstruction in a day. So it means that this fluid is accumulating in the gut. It's not in the bloodstream. So it means that there's a very high chance that this person here is going to be dehydrated, which is another reason why we're going to be instituting a lot of fluids. And we should run fluids initially when a patient comes in and you're suspecting that they have intestinal obstruction. So you get this accumulation of this fluid prior to the obstruction. And remember that you're also going to be swallowing some air, okay? Proximal to this dilatation. Remember, the dilatation is going to be caused by two things. Number one thing is going to be caused by the paralysis. The gut has pretty much given up. The second thing is going to be caused by the accumulation of these fluids. I'll give you another third reason as we move on later on. So you have this fluid that's accumulating proximal to this obstruction. You have the gut being paralyzed, so the proximal side begins to dilate. And you swallow a lot of air. And if you remember from your principles of physics, if you have air and water, water has a much larger density or it's much heavier than air. So it means that if you have it in a tube, the water is going to settle down at the bottom and the air will be on top. So you're going to be creating what is known as an air fluid interface. Now this air fluid interface can be seen on the X-ray. That's what we refer to when you do an erect abdominal X-ray as air fluid levels, where someone is standing. If someone stands and you take an abdominal X-ray, you call that an erect abdominal film. So you're going to be seeing these air fluid levels. You need more than two of them. So it means you need 3 or more air fluid levels for you to suspect that there could be some obstruction. And in addition to this, there's also going to be increase in transudation across capillary membranes because you have the venous drainage being affected. And you have this obstruction compressing on the veins, so the veins are not going to be taking blood away from this segment. So it means that the hydrostatic pressure inside the gut is going to increase. Inside the blood vessel, the veins of the gut are going to increase. So there's going to be movement of fluid out of the vascular space into the gut. So further increasing the dilatation, further increasing the dehydration. Then the walls of this obstructed gut are going to become edematous. And of course, the edema and the inflammation is going to be reducing the absorption. So it means that you have created another problem where even though you have a lot of this fluid in the gut, it's not going to be absorbed by the gut. So remember that this fluid and these electrolytes that are going to be accumulating in this obstructed lumen are going to be effectively lost because they're not in the blood. You refer to this as third spacing or third space loss. And in addition to this, some individuals may also vomit, and this vomiting and this third spacing is pretty much going to be contributing to fluid and electrolyte imbalances, fluid and electrolyte deficits. So in the first hour of the obstruction, the first 12 hours rather of the obstruction, there is only going to be decreased absorption. And so there is going to be accumulation of these fluids, accumulation of these electrolytes in the lumen. But pretty much there won't be any secretion that's happening from the gut. But after 12 hours, there's this accumulation of fluid already in the gut, decreased absorption, and in addition to this, the gut itself starts producing fluids. So there's going to be increased intestinal secretions, which is further going to be causing accumulation of fluid in the proximal space, and that's what's going to be causing the dilatation. And of course, if the small bowel is dilated, it means that even the abdomen is going to be dilated. So it means that the second feature that you're going to be seeing is abdominal distension. So you have severe colicky abdominal pain, you also have abdominal distension. Then here are air fluid levels. So in an upright chest x-ray, remember that you're going to be having water and air. Water is going to be having much higher density and it's going to be settling down. Air is going to be having much less density, so it's going to be floating above the water. So you create this air fluid interface, which we're going to be calling air fluid levels, which kind of look like a step ladder. If you see these lines here, this white area that's demarcated by this dark area, remember on x-ray, air is going to be dark, the fluid is going to be much brighter. So you get these air fluid levels here, which are kind of like these lines that you can see. And of course, this is the small bowel. Then you need more than 2 air fluid levels to make a diagnosis of obstruction. If you have more than 5 air fluid levels, then that would warrant operation because it may indicate that there's some ischemia that's happening to this gut. So here's a summary of what I have been talking about the progression of the intestinal obstruction proximal to the obstruction. So you have this intestinal obstruction that's going to cause increased peristalsis. That's going to be responsible for the to overcome the obstruction. If it fails, it's going to become vigorous. That's going to be responsible for the colicky severe abdominal pains. And then if the obstruction is not relieved, the peristalsis is going to cease. The bowel is going to become flaccid, paralyzed, and of course become dilated. In the first 12 hours, there's going to be decreased absorption. In the next 12 hours, there's even going to be some secretion of fluid into the lumen. And then you accumulate fluid into the lumen. It could be as high as 8 liters per day. Then the third reason why there is also going to be some bowel distension is that you're going to be having this bacterial overgrowth. Remember that you have all these nutrients that are accumulating proximal to the obstruction, all this water. So this makes a very conducive environment because remember the gut isn't really a sterile place. It has some normal flora in it. So proximal to this obstruction, you're going to have overproliferation of certain microorganisms, especially E. coli, Escherichia coli, especially Klebsiella, especially anaerobes, bacteroids, and even other organisms. Now, this is also another reason why we want to give antibiotics to a patient that has intestinal obstruction. Because these bacteria are going to start multiplying, and when they start multiplying, they'll produce toxins, and these toxins are the ones that are responsible for toxemia. So if this intestinal obstruction is not treated, it may actually lead to ischemia, it may cause necrosis, and eventually perforation. And when this perforates, all the contents are going to be released into the peritoneal cavity. They may cause a peritonitis. Okay, so you first have this inflammatory response in the wall of the gut. So you have this intramural inflammation. Of course, remember with acute inflammation, you're going to be recruiting neutrophils. So these neutrophils and eventually the macrophages are going to go into the muscles of the wall and they're going to be releasing reactive enzymes. They're going to be releasing cytokines that are further also going to be damaging the secretory as well as the motor function of the muscle. This is the third reason what is going to be leading to the dilatation of the proximal bowel. Remember, I've given you 3 reasons. One reason is because the gut is paralyzed and it becomes flaccid. The second reason is because you have accumulation of these fluids and swallowed air in the proximal aspect. The third reason is because you have this inflammatory cytokines and these enzymes that are going to be damaging the motor process or the contractility of the muscle and further causing the bowel dilatation. And then you also have an increase in the release of certain factors such as nitric oxide, as well as the production of intramural reactive oxygen metabolites that may actually affect the gut motility and may also affect the gut permeability. So in short, there's going to be some intestinal hypoxia that may also contribute to the dilatation. So remember that this dilatation is further going to increase the intraluminal pressure, and you have these contents that are accumulating in the lumen compressing on the walls of the gut. So it means that when they compress on the walls of the gut and the pressure in the lumen exceeds the pressure of the venous system inside the walls of the lumen, this is now going to be causing ischemia, because eventually even the arterial blood supply is going to be compromised. So if the arterial blood supply is compromised, there's going to be some ischemic injury that's going to be happening. And then, of course, this may lead to necrosis, gangrene, and eventually perforation. So these are the factors that are causing systemic problems in intestinal obstruction. So you may have some dilatation of the bowel. You may have decreased absorption across the mucosa. This is obviously in the first 12 hours. You may have increased secretion into the lumen in the next 12 hours. You may have intramural inflammation and hypoxia. You may have increased intraluminal pressure. You may have venous congestion and increase in venous pressure. And of course, you're going to be having a disruption in the mucosal barrier. So because now the blood supply is not intact anymore, the mucosa is also not going to be so intact. So it may begin to break, and it's easier for bacteria now to enter into the bloodstream and result in a septicemia, which could actually kill the patient. So we'll move on now to the site of obstruction. I hope you really understood what is happening proximal to the obstruction. So we're now going into the site of obstruction. So initially there's going to be venous return, which is going to be impaired. So this is going to be leading to congestion. There's going to be edema of the bowel wall, and then the bowel wall is going to be turning purple. And then later on, if the venous and this obstruction is not relieved, then there's going to be impairment of the arterial supply. So it means that the bowel is going to be losing its shininess, because bowel actually looks very shiny. If you see it in real life, it's very shiny and it's nice and pink. And if it loses that shininess and it starts to lose its color, so it means that it's going to begin to die. And even the peristaltic movements, you won't be able to see them anymore. It's going to be becoming blackish in color. So this is eventually going to be leading to gangrene that can cause perforation. It can lead to bacteria and toxins migrating into the peritoneum, leading to a peritonitis. And distal to this obstruction, because there's nothing going there, whatever was already there distal to the obstruction may be cleared out. So initially the patient may actually have had some bowel movements or even some diarrhea that may have stopped. And then after that, the bowel is going to be completely collapsed because it's not receiving any contents and it becomes inactive. So here's a summary of what I have been talking about. So proximal to the obstruction, there's going to be dilatation of the bowel. Here at the obstructed gangrenous bowel, it can actually even perforate. Then distal to this, it's going to be collapsed and inactive. So there are pretty much 4 cardinal features that are going to be pointing you towards intestinal obstruction. Not all 4 of them may be present. If they are, it means that you should really operate on that patient as soon as possible. Then there may be vomiting, there may be colicky abdominal pain, there may be abdominal distension, there may be absolute constipation. And all of these make sense. If you have the obstruction and the bowel is trying to overcome this obstruction, the peristalsis becomes vigorous, that's going to be causing the colicky abdominal pain. If you have this obstruction, the fluid accumulating proximal to this obstruction, you have also the gut secreting fluids proximal to this obstruction, the swallowed air that is present, the inflammatory reactions that are causing vasodilatation and increase in permeability, as well as dilatation of the wall, that's going to be leading to abdominal distension. Then, of course, the obstruction itself will mean that intestinal contents cannot go past this point. So it means that this person is not going to be pushing any air past this point. This person is not going to be pushing any intestinal contents past this point. So this person is going to be having absolute constipation. And of course, if the food isn't going forward, it's going to keep going backwards. So that's what's going to be leading to the vomiting. So all these things should make sense because science actually does make sense. So you may not have all these features at once, but you may sometimes have all of them. So we'll begin with the abdominal pain because that's often the first symptom that you're going to be getting. It's often sudden and it's going to be severe. It may be initially colicky, meaning it's severe pain in the abdomen that is often due to wind, sometimes even due to intestinal obstruction, and it may be intermittent. But if you get someone having constant pain, constant, continuous, severe pain, this may actually point towards 2 things. It may point you towards infarction of the bowel. It means that the blood supply has been affected, or it may be pointing you towards the onset of peritonitis. Then if it's a small bowel obstruction, the pain is often felt in the umbilical area. So it's periumbilical pain. and it's often going to be crampy, it's going to be recurrent, and it's going to be having these short episodes where it increases and decreases in severity. So you call that as short crescendo decrescendo episodes of about 30 seconds. So remember, at the end of this lecture, you should be able to distinguish small bowel obstruction versus large bowel obstruction on your history, on your physical examination, and according to your investigations. You should be able to distinguish between small bowel and large bowel obstruction. Then with the larger bowel obstruction or the distal obstruction, it often tends to be suprapubic pain, and it lasts longer, so it lasts minutes. Then with paralytic ileus or aerodynamic ileus, the pain is often diffuse and it's mild. It's not as severe as with this physical obstruction. Then it's very hard sometimes to tell post-operative obstruction because generally there's some discomfort that the patient comes in with from the operation, and also because you're flushing a lot of opiates, you're giving this person pethidine, you're giving this person a lot of analgesia, you may not be able to actually pick this up if a patient has post-op obstruction. So you really have to have a high index of suspicion. Then vomiting, remember that we have two types of intestinal obstructions according to the site. You can have high obstruction, which is common with the small bowel. You have low obstruction, which is common with the large bowel. So with the high obstruction, it is very early that you get vomiting. With the low obstruction, or even in the chronic type of obstruction, vomiting is usually a late sign. If you get large bowel obstruction and the patient is vomiting, it means you really have to do something because this person is in the late stages. So sometimes it may actually not even be there. If it's in the jejunum, it's actually early and persistent. Remember that I told you that the small bowel is divided into the duodenum, the jejunum, and the ileum. So if it's in the jejunum, the vomiting is usually early and persistent. If it's in the ileum, it's recurrent and it occurs at intervals. It may initially be bilious, but later it will become feculent. So it means it will have some feces in it. And this is obviously caused by this bacterial overgrowth that is happening proximal to the obstruction. But sometimes you may have this true fecal vomiting where someone is vomiting fecal matter. We only see that with gastrocolic fistulas. So that's not really, this person won't truly be vomiting fecal matter. You only have that if you have a gastrocolic fistula, which is an abnormal connection between the stomach and the colon, surrounded by epithelial tissue or granulating tissue. Then vomiting is a late feature that's seen in large bowel obstruction. And remember that the vomiting of the fluid in conjunction with the sequestration, the third spacing of the fluid in the gut, that's what's going to be causing rapid dehydration and significant water and electrolyte deficits, especially sodium, especially chloride. You may also have problems with potassium. Remember that cells are bags of potassium. So whenever the cells at the site of obstruction are beginning to die, they may release their potassium into the bloodstream. So then you may get a rise in potassium. Sodium is going to be low because this person is vomiting, and chloride is also going to be low because this person is vomiting and they're secreting these electrolytes. These electrolytes are remaining into the lumen. They're not being absorbed into the bloodstream. So the dehydration is going to be causing a rise in the PCV or the hematocrit. It's also going to be causing pre-renal failure or pre-renal acute kidney injury because the kidneys are not going to be receiving enough blood supply. And if the kidneys are not receiving enough blood supply due to the hypovolemia, it means that they're not able to excrete the urea, which will begin to rise in the blood. They are not able to actually even produce urine, which means that your urine output is going to reduce. Then with the abdominal distension, so remember that it becomes progressive and more marked with lower obstruction. So it's much more common with lower bowel obstruction than it is with higher bowel obstruction or upper bowel obstruction. And this is obviously due to accumulation of the gas and the fluids in the obstructed bowel. So if you have the jejunum, the abdominal distension may be absent or maybe slightly minimal. If it's with the ileum, you're actually going to be seeing the visible peristaltic waves. I've actually seen one of these on the wards. Then you may also get this characteristic sounds that you hear from the bowel, which are known as boborygmi sounds. So this is just simply this rumbling noise in the abdomen that's obviously caused by the gas in the intestines. So you have this stepladder peristalsis that you may also see. I'll show you a picture in the next slide. Then with large bowel, it usually tends to be enormous distension. So here's the stepladder peristalsis that you can see here. As you can see, there is this stepladder where the bowel is actually contracting. So sometimes you may have constipation, or you may also have constipation. So it can be absolute, meaning that there's no feces that are going through, there's no flatus that's being passed. So it means that on your history, it is very important to ask if this person is opening bowels, if this person is passing flatus. And constipation is usually a very early sign of large bowel obstruction, and it's a late sign of small bowel obstruction. Remember the difference between vomiting? It's the other way around. Vomiting is an early sign of small bowel obstruction, late sign of large bowel obstruction. Constipation is an early sign of large bowel obstruction. It's a late sign of small bowel obstruction. There are some exceptions though. You may have Richter's hernia, where you have a segment of bowel in the hernia that is obstructed. You may also get exceptions with gallstones. You may get exceptions with mesenteric vascular occlusion, even intestinal obstruction that's associated with a pelvic abscess. So some examination findings that you may see when you examine this patient. So you may get features of dehydration. So you're going to be having a poor skin tagger. You're going to be having hypotension. And of course, there may be persistent tachycardia. Sometimes there may be features of toxemia and septicemia. So there may be tachycardia. There may be tachypnea, which is an increase in respiratory rate. There may be fever. There may be sunken eyes. There may even be cold peripheries. And of course, if a patient is in pain, there may be rolling in bed and with colic. A good way to actually tell if this person has peritonitis, just simply ask them to cough. If they cough, they will be in pain because they'll irritate the peritoneum. Then when you take their temperature, they may be feverish, so they may be febrile. So this is obviously going to be due to inflammation in the bowel. It can be due to ischemia. It can be due to perforation. Or they may be hypothermic. If they're hypothermic, it's often due to septicemia because they lack that pyrogenic response. And if they are hypothermic, that carries a very poor prognosis because they may not actually survive. When you do your abdominal examination, so on inspection, you take note if you see any abdominal scars, like in the previous picture that I showed you. So if you see any abdominal scars, you should suspect that this obstruction is obviously caused by adhesions or bands. You note if there's any abdominal distension. Remember, I told you with large bowel, distension is going to be much greater than with small bowel distension. You check for any visible peristalsis that may be there. On the abdomen, if there's a hernia, check if it's strangulated. I shall show you the features of strangulation, I think, in the next slide. This is very common, especially with inguinal hernias or femoral hernias. You may also get it with umbilical hernias, but of course, it's very difficult in obese people or fat people. Then with palpation, on light palpation, there may obviously be abdominal tenderness. Initially, it's localized, but later can become diffused. So if it becomes diffused, it means that there may actually be some peritonitis that may be there. You may get rebound tenderness, which is known as Bloomberg's sign. You may also get guarding, where the person tenses the abdominal muscles when you try to palpate. So these are features of strangulation. Sometimes you may feel a mass. In intussusception, this mass may be actually sausage-shaped. So if you see a sausage-shaped mass that is very near to the umbilicus, it may point you towards intussusception. And of course, you may also palpate a mass in terms of carcinomas. Then when you percuss, of course, the abdomen may be resonant to percussion on the anterior aspect, and it will become dull to percussion in the flanks. Then on auscultation, you may sometimes have these increased high-pitched metallic sounds, which are just simply rushes and groans that are followed by metallic tinkling sounds of the bowel. And once, of course, the bowel has been fatigued, the bowel is tired, or it becomes gangrenous, then the bowel sounds may actually stop. So you may get a silent abdomen of peritonitis. Then in paralytic ileus, the bowel sounds are usually continuous metallic sounds of the dilated bowel. So when you do a digital rectal examination, the rectum is often empty, it may be dilated, and it may be tender. And if there's a rectal growth that is causing the obstruction, you may palpate it. And sometimes you may have a mass in the pouch of Douglas, or you may even palpate the apex of the intussusception, or even you may note that there's some fecal impaction where you see that there's heart stool in the rectum. Of course, you have to disimpact and remove it manually. It's a very nasty thing to do. Then you may also do a vaginal examination, which is obviously mandatory in females, and you should do this ideally before your rectal examination. So signs of strangulation, like I already told you, so you may get this continuous severe pain. There may be features of shock. There may be features of tenderness as well as rebound tenderness, what is referred to as Bloomberg's sign. You may have guarding and rigidity. You may have absent bowel sounds. And if it's with the hernias, there's going to be this tense swelling that is obviously tender. It's going to be rigid. It's going to be irreducible. And of course, there's going to be no expansible impulse on coughing. And there's going to be a history of recent increase in the size of the hernia. Some investigations that we may do. So we want to do some imaging. So we want to do a plain abdominal x-ray. So we're going to be doing two types of x-rays. We're going to be doing a supine x-ray where a patient is lying flat, which is obviously going to be showing abdominal distension, or rather intestinal distension. And then you also do an erect x-ray. Of course, if you suspect that there's perforation, also order for a chest x-ray and look for air under the right side of the diaphragm. Okay, remember on the left side of the diaphragm, you have a gastric bubble that is normally there. So do not confuse that with intestinal perforation. So on the erect x-ray, you may see there's multiple central air fluid levels in a stepladder fashion. In small bowel obstruction, in large bowel obstruction, they are less numerous and they're usually located in the flanks and as well as the suprapubic region. Now, how are you going to distinguish between small bowel and large bowel? There are certain characteristic features that you see on large bowel. So the small bowel are going to have these characteristic markings that are known as a valvulae conventae, or you can call it as a herringbone pattern, or you can call this as valves of Keckrin. They can also be referred to as plica secularis. Then in the ileum, it's usually smooth and characterless. The large bowel shows these hostrations of the tinea, and then of course sometimes you may get gas in the biliary tree, which is often due to gallstone ileus. You call those as pneumobilia. So here is an air fluid level. As we can see, what I've labeled here as the lines, the air fluid levels. So the triad that you get in small bowel obstruction on plain x-ray, you get this dilated small bowel that's greater than 3 centimeters. You get multiple air fluid levels in x-ray. And then, of course, you get paucity or smallness of air in the colon. So the colon won't have so much air in it. Remember also that the small bowel is often invisible on the x-ray. So if it becomes much more visible because there is accumulation of something, then you should suspect that there is some obstruction that is there. So here are the valvulae conventae that I was telling you. As you can see, you have these lines in the gut that are traversing or kind of like bisecting the small intestines, are running from edge to edge. You refer to these as valvulae conventae. And as you can see, this bowel is obstructed and it's in the center. It's distended and it's in the center over here. So you refer to this as a coiled spring appearance. It looks like a spring that has been coiled and put into the abdomen. So as we can see here, we can see that the small intestine has become much more visible. The dilatation is greater than 3 centimeters. You have these valvulae conventae that are present here, and you can't really appreciate the large bowel. So this is obviously a small bowel obstruction. Then with large bowel obstruction, you see these hostrations that usually don't traverse. They don't run from end to end. They stop somewhere in the middle over there. You get these hostrations. You can see this one here, this one here, this one here, this one here, this one here. And of course, it's in the peripheries. Okay, so you refer to this as a large bowel. That's how you're going to be distinguishing between small bowel and large bowel on the x-ray. So I will give you a table that summarizes everything that I've been talking about, because this is a very important thing to learn, because on your clinical exams, they're pretty much going to be asking you this. On your wards, they're going to be asking you this. So how do we distinguish small bowel from large bowel on x-ray? So small bowel is usually less than 3 centimeters wide. Large bowel is less than 6 centimeters wide. The cecum and the sigmoid could be up to even 9 centimeters. So you refer to this as the 3-6-9 rule. Small bowel less than 3 centimeters, large bowel less than 6 centimeters, but the cecum and the sigmoid can go up to 9 centimeters. Small bowel tends to be central. Large bowel tends to be in the periphery. Small bowel can only be seen if it has gas. Most of the times, it's not really seen on x-ray. Then the small bowel is going to having these mucosal folds, which you refer to as valvulae conventae or valves of Keckrin or plica secularis. And on obstruction, it may give you this coiled spring appearance. Then the ascending and the descending colon are often in fixed positions in the lateral aspect, whilst the transverse colon and the sigmoid colon can be in variable positions on the mesentery. Then the hostrations do not go all the way in the lumen, just like with the valvulae conventae, which go all the way in the lumen. Then, of course, the large bowel can contain this fecal mottled appearance. So you may get some additional features. So here are some additional features here. With large bowel obstruction, of course, the diameter here is greater than 5 centimeters. You get these hostrations, which do not traverse the entire lumen. You may get this cut off sign. So you reach a point where like the gut has been completely cut off. You see this position here where it's like you have this large bowel, large bowel, large bowel, large bowel that has been cut off there. Okay. Then with paralytic ileus, you may have this gas both in the large and the small bowel. There's no cutoff sign, so the bowel is continuous through and through. Then in small bowel obstruction, I already explained this. So you have this dilatation that's greater than 3 centimeters. The distension is central, so it's like a picture, while here it's like a frame on the sides. Then you have valvulae conventes, you have multiple air fluid levels, you have absent gas in the large bowel, and then of course a step ladder appearance. So take your time to actually learn these signs on the X-ray because they become very, very important for you to know. Other investigations that we may order: a chest X-ray that may obviously show elevation of the diaphragm, which is obviously going to be secondary to abdominal distension. You may also see air under the right side of the diaphragm, especially if someone has an intestinal perforation. You get what is known as a double diaphragm sign. So it would be like that two diaphragm markings that you can see. Then you may have abdominal ultrasound that may show a dilated bowel and fluid in the peritoneal cavity. It's much better than an X-ray, but not as good as a CT. You may also sometimes do a Doppler ultrasound that may be useful in detecting any strangulation that may be present. Also order for a barium enema X-ray that is useful in intussusception, only when you're suspecting intussusception, because barium mills and generally barium studies are contraindicated in acute intestinal obstructions, because if there's a perforation and you administer contrast and it goes into the peritoneum, it will lead to peritonitis. So that's why we generally tend to avoid them, and I generally don't really order them for my patients when they come in with intestinal obstruction. Then order for a CT scan sometimes, but of course you won't even have this time to order for a CT scan because it may take a while. So it's very reliable in investigating intestinal obstruction. So it will give you an idea of how the bowel wall is. It will give you an idea if there is any features of ischemia, any features of strangulation, any mesenteric edema or thickening. And of course it may show that there's bowel wall gas. Sometimes there may be gas in the portal venous system. There may sometimes be a mass, like a tumor, that you can pick up on your CT scan. Then other investigations include blood investigations. So you may order a complete blood count or a full blood count with a differential count. You want to check your hemoglobin. This is a patient that may be going to theater. The hematocrit here or the PCV may be raised because of dehydration. Then of course the white blood cell count may be normal or slightly elevated if there is a bowel infarction or peritonitis. Urea, electrolytes, and creatinine, there may be a raised urea and creatinine because of this pre-renal acute kidney injury that is due to the hypovolemia. You may also get low levels of sodium and chloride, I already explained, as well as the hyperkalemia, which I explained because the gut is beginning to die. You may also want to order for your liver function test, as well as your arterial blood gases that may show acidosis. So here's a table summarizing every single thing that I've been talking about how you're going to be distinguishing between small bowel, large bowel, on clinical features, on causes, on investigations. So we'll begin with small bowel. So here in this table, they have actually divided it into proximal small bowel and distal small bowel versus large bowel. So proximal small bowel is of course the duodenum and the jejunum. The distal small bowel is obviously the ileum. So here are some of the causes. So you have congenital causes, lipomas, leiomyomas, malignancies, bands and adhesions. Whilst with distal small bowel, you have TB strictures, malignancies, Crohn's disease, gallstones, hernias, which are by far the commonest cause, roundworms, and it could also be congenital. In large bowel, it cannot occur anywhere on the large intestine. So you could have malignancies, TB strictures, anorectal malformations, volvulus, congenital megacolon, or bands. And then clinical features: in proximal small bowel, you have severe vomiting, you have dehydration, and there is no or very minimal distension and colicky abdominal pain. Then if it's affecting the ileum, there's going to be central distension, there's going to be vomiting, some dehydration, there's also going to be central abdominal pain, so periumbilical pain. And then in large bowel, there's going to be constipation. Distension is a very early feature, so it's markedly distended. There's obviously going to be vomiting, which is a late feature, okay? And there's less pain. Then on X-ray, the small bowel is going to be showing valvulae conventes, that's the duodenum, and the jejunum, whilst the ileum is going to be characterless and you have the central air fluid levels. Then of course the large bowel are going to be dilated on the peripheries with horstrations. So these are how you're going to be distinguishing between small bowel versus large bowel. So some complications that may be associated with intestinal obstruction include hypovolemia, septic shock. You may have perforation that may lead to peritonitis, that may lead to an intra-abdominal abscess that forms. Sometimes you may have acute respiratory distress syndrome, and you may have renal failure or acute kidney injury. Now, management of this condition, because this is very, very important for you to know, it's an emergency, so you should know exactly what to do. So you want to resuscitate your patient, so you're going to be doing your ABCs, ensuring that the airway is patent, ensure that the patient is breathing, gain venous access, draw blood for investigations, and start running fluids. You want to decompress the obstructed gut because there's a lot of things that are accumulating proximal to the obstruction. There's air that's accumulating there. There is fluid that is accumulating proximal to this. So you want to decompress the obstructed gut. Then you want to replace the fluid and electrolytes that have been lost due to the third spacing. And then, of course, you want to address the underlying cause. Some cases, we may do conservative measures to manage intestinal obstruction. In some cases, there may be surgical interventions. So you have to take note that you may have acute obstructions. You may also have chronic large bowel obstruction. So with acute obstruction, this is where the obstruction is sudden and it's complete, and there's a very high risk of strangulation. So it means that this is an urgent problem and it requires urgent intervention. So you do an emergency surgical intervention. Then with chronic large bowel obstruction, it's slowly progressive and you can actually investigate it with some leisure. You may do a sigmoidoscopy, you may do a colonoscopy, sometimes even a barium enema, and this is often treated electively. Now, in resuscitation and decompression, like I already told you, you want to do your resuscitative measures, so your ABCs. You want to push in an NG tube, a nasogastric tube. And when you push in this nasogastric tube, make sure you aspirate the tube at least every hour and then leave it connected to a bag so that it drains and it keeps draining, removing the air, removing the fluid that has accumulated in the stomach and in the proximal bowel, proximal to that obstruction. Then, of course, you measure the aspirate that you are getting from this NG tube, and you're using this to calculate how much fluids and electrolytes you're going to be using to push in. So you're going to be needing an input-output chart. So if you're managing a patient conservatively, then the daily amount of the aspirate must reduce. The nature of the aspirate must also become clear. Sometimes it may have some bowel staining. So the fluid must not be thick, it must not be dark, it must start to clear up. And the reason why we push in the NG tube is it reduces the toxic effects on the proximal bowel. It reduces the distension. It also improves the pulmonary ventilation because the abdominal pressure and the abdominal distension is less. So there's much less pressure on the diaphragm. So it means that breathing is made much more better. So it also reduces the possibility of developing aspiration pneumonias. Then with fluid and electrolyte therapy, so you want to give your electrolytes and fluids via IV. So the fluids that you can give is Ringer's lactate, normal saline, as well as 5% dextrose. So initially you want to administer large amounts. So you give 1 liter every 3 to 4 hours to replace these losses, and then you can give maintenance until they return to normal bowel function. You measure the potassium daily, and you meet their potassium requirement that of about 40 to 120 millimoles in a day, with an infusion of about 60 to 80 potassium chloride that can be divided over 24 hours. But with my general experience, we usually don't give potassium, because the reason why we don't give potassium is because it requires ECG monitoring constant. Because if you give this potassium and the potassium concentration increases beyond the normal, then you may tip this person into developing arrhythmias. Sometimes the heart can stop. And if they have hypokalemia and it's very severe, then you have to give 40 millimoles that can be infused over an hour in 400 mils of fluid. Remember, do not give potassium as a bolus. Do not push all of it in at once, because you may cause cardiac arrhythmias. You may sometimes even stop a person's heart. Catheterize this patient, monitor the urine output. So like I said, open an input-output chart. Then some special conservative measures. We may sometimes manage this person conservatively. Like, for example, if you want to pass a rectal tube or a flexible sigmoidoscopy to deflate the sigmoid volvulus, sometimes you may do a barium contrast enema to reduce an intussusception in the early phases, like for example in an infant that you do not necessarily want to operate on. If there's an impaction, you want to remove the feces manually, or you can do an oil retention enema to reduce the obstruction. And then of course, it's also very important to assess that this conservative management that you're doing is working. So how do you confirm this? There should be a relief of symptoms. So if there was vomiting and pain, it should go away. There should be an improvement of the general condition of the patient. This patient must start to look brighter. The vital signs must improve. The pulse rate must be normal. The temperature must be normal. The blood pressure must be normal. And of course, they should be in some of these observations must also be there. There should be a reduction in the amount of aspirate, even the consistency of the aspirate that's coming from the NG tube. The abdominal girth should reduce, so the distension should reduce, and there should also obviously be return of the normal bowel sounds. Then if the intestinal obstruction is often due to adhesions, it often settles with conservative management according to my experience, unless if it's strangulated or unless if the feature of peritonitis, of which you have to take the patient to surgery. Now, with conservative management, there's a time limit. You can't keep having conservative management and praying and hoping. So your limit should be at least 3 days. At most, if you have 1 or 2 days, you keep the patient 1 or 2 days, they should show some improvement. If they do not show improvement within 3 days, please take them to theater. So some surgical interventions, the indication for surgery is if there's evidence of strangulation, if the patient doesn't improve with conservative management after 72 hours, if there are signs of peritonitis, okay, or if the intestinal obstruction is acute and severe, then please take them to theater. So we can do an immediate laparotomy, or you can use a laparoscopic approach. An immediate laparotomy, when you go and open up the patient, you may check which bowel is viable and which is not. A very good way to actually do this is get like an abdominal pack, soak it in some warm saline, and then administer 100% oxygen via inhalation for about 20 minutes. Cover this this area where you think that there's some doubt, and then after about a few minutes, if the color returns back to normal, the peristalsis also returns back to normal, then most likely that this bowel is still viable, so you can still keep it. Then if it's not, then you can cut it off. You can resect and anastomose it, and then you obviously wash the peritoneum with some saline, warm saline, and then of course leave an abdominal drain there, and then you close the abdomen obviously in layers using your non-absorbable sutures and using tension sutures. Then with a laparoscopic management, where you use a laparoscopy, usually you make a small incision. This is obviously done with partial obstructions, with obstructions that are due to bands. And when you're doing this, you should be ready to convert it to a laparotomy. If you fail to manage to do this laparoscopic, you should have facilities to simply rush the patient and convert it into an open surgery. Then, of course, sometimes you may place a defunctioning colostomy or an ileostomy to actually minimize the complications of your anastomosis leaking. So these are the things that you check for in theater when you want to check if there's any viability of the bowel. So you want to look at presence of peristalsis. You want to look at some pulsations. So there may be some pulsations. You may feel some pulsations of the gut. You look at the color. So if it's either pink, it's normal. If it's darkish, if it has lost its color and its shine, that luster, if it's lusterless and the serosa is looking dull, then that's most likely pointing you towards ischemia. So if the serosa loses its shine, if there's any bleeding in the mesentery or the bowel, then those are good signs. Then, of course, if it's friable and the muscles are flabby, that means that that's pointing you towards ischemia. So these are just some of the features that you're going to be checking for in the theater to assess whether this bowel is viable or not. Some additional measures that you may actually give for this patient. So you ideally want to admit them to the ICU after the surgery. Before the surgery, please start intravenous antibiotics. So a good combination would be your cephalosporins. So you could use your ceftriaxone combined with metronidazole. IV, of course, you could also alternatively use ampicillin. You could also use gentamicin. Give analgesia to this patient. Of course, do a cross match. You may want to transfuse some fresh frozen plasma or platelets in critical patients. You could also perform central venous pressure monitoring, or you can give fluids via the central venous lines. So you want to measure your pulmonary capillary wedge pressure, and this is obviously very good for patients that are hemodynamically unstable. Some post-surgical complications include things like pelvic abscesses, subphrenic abscesses. You could have biliary or fecal fistulas. You may have a burst abdomen. You may have bands and adhesions after the surgery. And of course, incisional hernias, where part of the bowel or viscus protrudes through this incision. Thank you for taking your time to listen to this review lecture video. I hope you really understood on intestinal obstruction, and the next time you get a patient that has obstruction, you will know exactly what to do. If you haven't yet subscribed to the channel, please subscribe to the channel, drop a like, drop a comment. I will surely appreciate. Hit the bell notification icon to be receiving notifications of videos every time I post. Thank you. My name is Dr. Moses Kazevou.